Good evening, and welcome to the evening rounds. I'm Dr. Nicole Leong. I'm an assistant professor in the section of general obstetrics and gynecology at the University of Chicago Medicine. Tonight's session, we will be focusing on nausea and vomiting in pregnancy and hyperemesis gravidarum. And we'll briefly be talking about the assessment of nausea and vomiting in pregnancy and hyperemesis, as well as the management, potential complications, and future pregnancies and how to help manage symptoms in future pregnancies as well. This session is part of our continuing education series for OBGYN nurses and medical assistants. And I thank you very much for joining us tonight. I have no financial disclosures. Okay, and this is just a review of the things that we will be discussing today. So one of the things that we would like to distinguish is nausea and vomiting in pregnancy versus hyperemesis gravidarum, how to use objective scores to assess the severity of nausea, vomiting in pregnancy and hyperemesis, understand the evaluation and complications, how to apply a stepwise treatment algorithm for nausea and vomiting in pregnancy, and to recognize when things should be escalated and admission to the hospital might be required. Some general background, nausea and vomiting in pregnancy is a major cause of hospital admission in early pregnancy, and the second most frequent cause of admission in the second trimester as well. Nausea and vomiting in pregnancy affects up to 90% of pregnancies, whereas hyperemesis gravidarum affects a much smaller percentage of people, anywhere between 0.3 to 3.6% of pregnant people. And this can have a significant impact on nutrition, as well as quality of life for pregnant people. And addressing this seriously and as soon as we can help prevent this significant impact on people's lives. Typically, nausea and vomiting in pregnancy starts between 4 to 7 weeks of gestation. It peaks approximately in the 9th week, and most of the time, in about 90% of people, it will resolve by the 20th week. It used to be thought that nausea, vomiting in pregnancy was associated with the pregnancy hormone or HCG levels. However, newer studies have shown that the major mechanism of nausea, vomiting, pregnancy, and hyperemesis gravidarum is related to something called the hormone growth factor the hormone growth differentiation factor 15, or GDF15. This is secreted by the fetus and the placenta. And higher levels of this and increased sensitivity to GDF15 appear to be the greatest risk factors for hyperemesis gravidarum. And future research is looking at how blocking people's response to GDF15, either blocking the secretion of it or desensitizing people who are genetically predisposed to this, can help treat hyperemesis in the future. Looking at our definitions, so nausea, vomiting, pregnancy, what it sounds like, nausea or vomiting during your pregnancy with an onset prior to 16 weeks of pregnancy, and at the same time ruling out any other causes of nausea and vomiting, which we'll talk about in a few slides from here. Hyperemesis gravidarum, however, is also nausea and vomiting in pregnancy, but it is severe enough to cause inability to eat or drink normally, as well as strongly limiting daily activities of living. In the past, we relied heavily on more objective measures, such as people losing weight. Are they having electrolyte imbalances in order to diagnose people with hyperemesis? However, we're moving more to a subjective measure, more patient-focused criteria, such as inability to do your normal functioning. Signs of dehydration can contribute to our diagnosis too, but really it is a matter of how it's affecting people's lives. Ketonuria used to be used as a criteria for dehydration, but that really should not be used as part of our assessment of severity of nausea and vomiting in pregnancy. This is a review article that came out of the Lancet, and it sort of reviews the Royal College of Obstetrics and Gynecology's practice management recommendations that are published there. They're a little bit more up to date than our American College of Obstetrics and Gynecology practice bulletin. So this is a review of some other signs and symptoms that can accompany hyperemesis and nausea and vomiting in pregnancy, aside from of course, nausea and vomiting. One of the most common other symptoms that people have is ptyalism, which is basically just a very excessive amount of saliva that's created. And so people are constantly feeling like they have to spit this saliva out, and it can be quite distressing for people. Unfortunately, there's not a lot of good evidence for treatments for this particular symptom. Other symptoms people might experience are reflux or GERD symptoms. About 2/3 of people with hyperemesis are going to experience this and can lead to more severe complications like erosive esophagitis or GI bleeding, scarring or strictures in the esophagus as well. And we should be assessing for this for any kind of red flag symptoms to make sure that there's not something more serious going on. Other things that we might see often are disturbances in your thyroid function testing. So HCG is a molecule that appears similar to our TSH, or thyroid stimulating hormone, or thyrotropin. And so these HCG, when it's elevated, it can cross-bind to the TSH receptor and stimulate thyroxine production. So we can have sort of a transient hyperthyroidism. But oftentimes this is not really symptomatic. It's more biochemical. And as nausea and vomiting improves, and as you move out of the first trimester, oftentimes this resolves on its own. If people are having symptoms of hyperthyroidism, then this is something that needs to be evaluated further. Other things that we can see, sometimes we'll see liver enzyme disturbances, especially with Hyperemesis gravidarum. Oftentimes our AST or ALT and our liver enzymes can be elevated. Most of the time, this does not need further evaluation unless we're really looking at levels that are over 5 times the normal limit of the upper limit of normal. And so this will oftentimes resolve as the nausea and vomiting gets better as well. So as I mentioned before, nausea, vomiting in pregnancy and hyperemesis is really a diagnosis of exclusion. So we need to make sure that we're evaluating for other potential causes of severe nausea and vomiting in pregnancy. And this is from the same article that I mentioned from the Lancet. And it breaks down into different categories. So you can have neurologic symptoms that can be associated with nausea and vomiting, such as severe migraines, things that affect your vestibular function, like vertigo. Also, things like high intracranial pressure can cause severe headaches, and then nausea and vomiting as well. Gastrointestinal things, so some things like a viral infection might cause nausea and vomiting. So gastroenteritis. Severe reflux can make people pretty nauseated. They might vomit from this. Something more severe like hepatitis or other kind of biliary disease like gallstones or gallstone pancreatitis. More rare things like GI malignancies are in the back of our mind. Somebody who has severe diabetes might have bad gastroparesis. So their GI function is just not moving in the normal way, and that causes nausea and vomiting as well. And then appendicitis in somebody who has like severe right lower quadrant pain or other symptoms is something else to keep in the back of our minds. So metabolic Dysfunction can also cause nausea and vomiting. So in somebody who's diabetic, if they're experienced diabetic ketoacidosis, that can cause this. Other things like hypercalcemia, adrenal insufficiency, true hyperthyroidism, and uremia can also result in these types of symptoms. And then lastly is sort of this other category. So someone who has a severe urinary tract infection could have vomiting. And then sometimes we have psychiatric disorders that can make this worse. So someone who has an eating disorder already, who has, strong fear of gaining weight or eating, and then ruling out a cardiac syndrome like a heart attack or something like that, which would be pretty rare. In most instances, when we're in the first trimester and we have nausea and vomiting or hyperemesis, it is truly just nausea, vomiting at pregnancy. But we do have to make sure that we're not missing something that could be more severe. Okay, so when you are talking to somebody on the phone, they're calling in and they're reporting these types of symptoms. These are kind of the sort of things that we should be triaging somebody, asking about their history. So if this is someone's not their first pregnancy, and ask, did you have nausea, vomiting in pregnancy or hyperemesis in previous pregnancies? And that can sort of push us to not worry so much about the more rare things like appendicitis and whatnot that we just discussed. And it is very common for nausea and vomiting in a previous pregnancy to recur again in future pregnancies. And then on the phone, it can be very helpful to use these questionnaires to score how severe somebody's nausea and vomiting is, and in order to escalate to the physicians or writing prescriptions and things like that. And we'll go over what those scores look like. It's also important to ask about comorbidities that can be affected by the inability to take your medications. So if somebody needs to be on a daily medication, but they're vomiting, they're not able to take that medication, how serious is that? Your prenatal vitamin, you can't take it every day. That's okay. We're not going to worry about that. But as someone who is epileptic and needs to take their anti-seizure medications, then that is something that could be very dangerous for them if they're not able to take that, because it could lead to seizures. Other examples are HIV medications, your psychiatric medications, and antihypertensive medications, as well as somebody who has diabetes. So that is not necessarily that you can't take your medication, but if you're not able to eat, but you're giving yourself insulin or you're taking other medications that could make you hypoglycemic or lead to diabetic ketoacidosis, this is very important. And then hypoadrenalism, if you're taking steroids, that is also something that we need to be aware of. In addition to other medical conditions that somebody might have, we would want to get a surgical history as well, specifically whether or not somebody has had any type of gastric weight loss surgery, like gastric bypass, band, or sleeve, because this can make it much more. Okay. And then again, the last thing is to exclude other causes, and we kind of went through that already. Okay, so this is something that is called the puke score, and this is how we can use questionnaires to quantify how severe someone's nausea or vomiting is. It's a very cute name. It has been validated to assess for the severity of nausea and vomiting. So it's pretty basic, 3 questions. In the last 24 hours, how long have you felt nauseated or sick to your stomach? That's for not at all, 1 hour or less, 2 to 3 hours, 4 to 6 hours, or more than 6 hours a day. It talks about in the last 24 hours, have you vomited or thrown up? And it quantifies how many times, and you get certain points for each one of these levels. And then in the last 24 hours, how many times have you had retching or dry heaving without bringing anything up? And then you add up the score, and mild is less than or equal to 6, moderate 7 to 12, and severe greater than 13. And then ask some other general questions about how someone is doing, how their well-being is, like how would you rate your own well-being, how many hours have you been able to sleep. It can kind of add some additional information to how someone's coping and how their life. This questionnaire has not been validated to monitor response to treatment. There's another questionnaire. This is the HELP score, and it has been validated to track how someone's progress is. So if we are monitoring treatment, we can give this questionnaire again to make sure that things are improving. It has a little bit more extensive questioning, but this is another option to use. I think the puke score is kind of nice because it is simple, 3 questions. And then, something is more moderate to severe and we're thinking we need medications prescribed, we can escalate to the physician or the midwife or our physician's assistants to help with that. This one is online at this website here that you can see too. Okay, aside from assessing someone's symptoms and the severity of the symptoms, other things that we might do to evaluate someone's nausea and vomiting are some blood work. So initially we can check a urinalysis, and that can evaluate for a urinary tract infection to make sure that we're not missing something else that might be causing nausea and vomiting or illness, as well as it can assess someone's dehydration levels too. So if the urine is extremely concentrated, that could be a sign of dehydration, and maybe we need to escalate treatment. We're going to check electrolytes, and with a basic metabolic panel, we're looking at creatinine and electrolytes, evaluating for sodium levels, and evaluating for potassium. If the creatinine is very high, it could be a sign of severe dehydration too. We can check a blood glucose just to rule out in someone who's diabetic, a DKA. A complete blood count with a differential can evaluate for other signs of infection. And then lastly, an ultrasound, one to check for a viable intrauterine pregnancy. We can also check for multiple gestations because that is associated with nausea and vomiting and hyperemesis, to have twins or triplets. And then evaluate for gestational trophoblastic disease, so a molar pregnancy or a partial molar pregnancy, which is also a risk factor for developing hyperemesis. And then if we're evaluating somebody who's getting admitted to the hospital, we may do more extensive testing, like the thyroid function test, your liver function test, check for other tests like calcium in your phosphorus, rule out pancreatitis with an amylase, and then we can evaluate metabolic disturbances with a blood gas as well. But this is if somebody is more severe and we're admitting to the hospital, then we can move on to these types of tests. Okay. Next is to talk about management in nausea, vomiting, pregnancy, and hyperemesis. So initially, somebody who may score very low on the puke score, but is nauseated, they're still able to tolerate some hydration and a little bit of food, we may just advise on some lifestyle and dietary things. So allowing somebody to take a little bit of time off work, so we can help with intermittent FMLA or whatever they need to have for work so that they can rest. And then more frequent but very small snacks or meals throughout the day to just prevent an empty stomach can help. And then really minimizing triggers. Some people have more triggers with like brushing their teeth or smells or cooking certain things. So just trying to avoid whatever triggers nausea and vomiting can initially be very helpful for people with very mild symptoms. Treating early with antiemetics, however, can help potentially reduce progression to hyperemesis. So if someone is has a little bit more symptoms, we don't want to wait until they're at the point where they can't tolerate PO at all, and they're dehydrated. So getting on top of things and offering oral antiemetics early can help reduce the progression and the severity of things. And then ramping up pretty quickly to combination therapies. We'll talk about what's available and trying to get get a handle on their nausea and vomiting before it gets too severe. And then we can offer IV fluids, and we'll talk about the vitamins that we should be adding to our IV fluids. And then, of course, if something is not working, how do we escalate to the next step to inpatient management? What do we need to do from there? And then this is more of a detailed algorithm of what I just kind of mentioned, and how we would want to manage things. And this is a pretty nice algorithm it's from the British Journal of Obstetrics and Gynecology in 2024. And initial assessment is made. And then we can do severity assessment using the puke score. We can talk about weight loss, other measurements that might signify a very severe hyperemesis. And then this goes through kind of what do we do for each sort of level of things, right? So someone who has more mild to moderate nausea, vomiting, and pregnancy, and we're not concerned about other comorbidities or complications that could potentially happen with not being able to take medications, et cetera, that I mentioned before. We can start with our antiemetic therapy and sort of reassure our patients that, yes, these things are safe to take. I'll go through what's first line, second line, third line treatments in just a second. Trying to make sure people are able to take fluids in or some oral rehydration therapy, and then addressing the other things that could make things worse, like constipation, heartburn, GERD, and then assessing people's mental health and how they're coping with this. And then we want to follow up and reassess within 1 to 3 days to make sure that things are not getting worse and the things that we're offering are helping. If someone's not getting better, we can add additional antiemetics. And then we can, get people in for either like in our infusion center here, we can do IV fluids and medications as an outpatient versus admitting somebody to the hospital. And then there's this little red box here that talks about when we should really be thinking, does this patient need to be in the hospital? Right? So you cannot eat or drink at all. And some of the outpatient stuff that we've tried is not working. We're really dehydrated. Or we think that somebody needs IV antibiotics or they need management of DKA, they need to go into the hospital. And then for those concerns about medications needing to be given, if you can't take them orally, do we convert those to IV medications as an inpatient? That's what we want to be thinking about. Okay, in terms of antiemetics, there haven't been head-to-head trials on these medications, at least extensively. And so most of the recommendations for what we should be giving in terms of antiemetics are really based on safety data rather than efficacy data. And so a lot of the trials that have been done are pretty limited, but we do know that doxalamine, or our antihistamine sleep medication, doxalamine, and then pyridoxine, which is vitamin B6. It's kind of our first line treatment. We know that this is safe to take, and it has some good evidence that symptoms have, compared to placebo, symptoms do improve quickly. Although the placebo group also had improvement in this, but it can be effective in reducing the puke score. This is how the research is done, evaluating how the puke score goes. Other medications that we can offer are prochlorperazine, which is the brand name Compazine, promethazine or Phenergan, clopromazine, chlorpromazine, which is thorazine, which we don't use very often. And then diphenhydramine or Benadryl, and then dimenhydrinate or Dramamine. So a lot of these are over-the-counter medications that could be tried, as well as given as a prescription. And so these are kind of our first line treatments, the antihistamines, and then these other medications, which are dopamine receptor antagonist drugs. And some of the research does show that they can be effective, but there, like I said, there is not a whole lot of really robust research on which one to choose first. So typically, I think because we do have good evidence of safety, we'll start with the doxalamine and pyridoxine combination, and you can start it at night only. It does make you sleepy because it is an antihistamine. So if someone has to work throughout the day and it's difficult for them to take this medication in the day, they can take it at night only. And then we can add some of the second line therapies for during the daytime. And I'll show you what those are in the next slide. These are our second line therapies, which include ondansetron and metoclopramide. And there have been some small randomized trials that show that ondansetron seems to be superior to our doxalamine pyridoxine combination in reducing our nausea and vomiting. It's probably on the same level as metoclopramide, the ondansetron and metoclopramide, but there may be less side effects with the ondansetron than the metoclopramide. And so ondansetron, we give 8 milligrams every 8 hours. We do have a dissolving tablet that goes on under the tongue or in the cheek, and that can just dissolve if someone's not able to take a pill. Some of the side effects associated with ondansetron, people can get headaches, drowsiness, fatigue, and constipation is the most common thing that I hear about, and that can be quite severe. So making sure we're addressing constipation with stool softeners, fiber supplements, Miralax to combat this side effect can make people much happier, because constipation can be just as miserable as nausea and vomiting sometimes. One thing we get concerned about with using ondansetron is a resulting prolonged QT interval and causing life-threatening arrhythmias. So if someone has a personal or family history of a long QT syndrome, we want to get an EKG first. Or if they have any kind of cardiac abnormalities like heart failure, someone who is got severe electrolyte derangements like hypokalemia, hypomagnesia, they are at more risk for having this prolonged QT and then heart arrhythmias. On the right side of this slide, you can see that there are some medications that can make this worse. And so trying to avoid a combination of the ondansetron plus these other medications here it would be prudent. In the recent past, there have been some studies that raise concern about ondansetron and cardiac defects or cleft palate. But this data is really conflicting, and most of the big review studies have shown that this is not considered really a risk anymore. And so the reason that these studies were potentially flawed is that they were looking at people who were taking ondansetron for nausea and vomiting in pregnancy. And then they were comparing them to people who were not taking anything at all for nausea and vomiting. And so those may be two separate different groups, and people who have nausea and vomiting in pregnancy, potentially they're at higher risk of cleft palate or cardiac defects versus people who have no nausea, vomiting at all. So it's comparing apples to oranges, and that kind of leads to some confounding based on the indication for the medication rather than the medication itself causing these things. And then there have been, like I said, more systematic reviews and meta-analysis that have come out to conclude that there really do not seem to be any major malformations, heart defects, cleft palates associated with ondansetron in the first trimester. So we can reassure our patients that this is safe medication to take. If you look at those studies that found that association and you assume, okay, well, maybe that really is a real association, then the number of people who have to take ondansetron to result in a cleft palate, it was 10,000 births and 3 additional cleft palates. If I said that, that makes sense. So if we look at people, there were 3 additional cleft palates per 10,000 births. And that's assuming that, we were incorrect in our analysis of these studies, and this is true association. So it's a really rare thing. But overall, we do not think this association actually exists. And so I think we can be reassured that it's very safe to take. Metoclopramide, we give 10 milligrams by mouth every 6 hours. Again, we have similar side effects of drowsiness, fatigue, and restlessness. But we can have some very rare sort of neurologic complications, side effects from this medication, more associated with really long-term use of metoclopramide. And these are extrapyramidal side effects, such as dystonia. Dystonia is a movement disorder. So you have like these repetitive kind of abnormal movements or postures. And this is something that is not reversible. The other side effect is tardive dyskinesia. And this is also associated with long-term use of these medications. And it's kind of like also a movement disorder, kind of this hyperkinetic movement. And it's, again, associated with chronic use more so than the short-term use that we're hopefully using during pregnancy. Okay, and then if all of those medications fail and we're still having someone with severe symptoms, hyperemesis gravidarum, steroid treatment can also be considered. There's not really an agreed upon practice like what steroid to choose or how often to give it. But one example is using methylprednisolone, and you do a taper. So 16 milligrams every 8 hours for 3 days, and then you taper it down using prednisone over about 2 weeks. And side effects of this complications can be resulting hypertension. It can increase our risk of maternal infection when someone's on steroids, and it has been associated with preterm premature rupture of membranes as well. In terms of safety, other safety for fetal safety, the rate of like oral facial cleft malformations does not seem to be increased with the use of steroids in the first trimester. It's not our first choice. It is down the line if nothing else is working, but it is quite effective in someone who has a severe case of hyperemesis. This is just kind of a sort of a zoomed in view of these red flag symptoms. So just something to keep in mind if you have complications, that's somebody who may need inpatient treatment or can't eat or drink anything at all. Our outpatient management has not worked. We're really dehydrated. We have some sort of comorbidity that we're worried about, or can't take our medications. It's very important that we need to take our medications. And then, of course, looking at someone's mental health and how they're coping with pregnancy or nausea, vomiting, or pregnancy or hyperemesis as well. Sort of our last kind of resort things that we can do when someone's admitted to the hospital for a long period of time and they're not getting better is parenteral nutrition. So this is really only a kind of last resort. Thing like TPN or enteral tube feeds. These are also potentials to help with like serious malnutrition in somebody. And so that's what this talks about here. TPN, it is associated with complications like increased risk of thrombosis. You can have metabolic disturbances once you start TPN, and you're at much higher risk of infection when someone is on TPN as well. And then tube feeds, pretty hard for people to tolerate. Like an NG tube actually could be so irritating to your throat. It makes nausea and vomiting worse potentially. You could do a nasojejunal feed, which has to be placed really endoscopically or on ultrasound, and that could potentially help. And then there is GJ tube feeds, so you can put a PEG tube in and then feed that way, but there can be complications with that as well. It can get dislodged, it can get obstructed, cause fistula. So these are kind of like really last resort things in a highly desired pregnancy and severe hyperemesis. And then lastly, some people do choose to terminate a pregnancy when they can't manage these symptoms. And most of the time it's because they can't, help take care of their families, or it's just so mentally draining to feel this way that people might choose to terminate a pregnancy. So moving on to some sort of potentially life-threatening complications of severe nausea and vomiting. I think one of the big things we think about is something called Wernicke's encephalopathy. And so this is a result of chronic vitamin B1 or thiamine deficiency. And so oftentimes when we have IV fluids, someone who requires IV fluids will add thiamine to their IV fluids in order to prevent Wernicke's encephalopathy. And this can look like nystagmus, ataxia, and confusion. It's kind of the triad of classic symptoms for this. And oftentimes it can be precipitated by giving someone who is deficient, suddenly giving them glucose through their IV. So oftentimes we'll do IV fluids with just normal saline and not add glucose to that until their thiamine is repleted safely. Other things that we can see is a neurologic complication called central pontine myelinosis. So if someone's hyponatremic and we overcorrect too quickly their sodium, that can precipitate swelling in the brain and then cause this complication. So if we are giving IV fluids, maybe we monitor their electrolytes more closely. Other things that we worry about are arrhythmias. Somebody who's has electrolyte abnormalities due to dehydration or acute kidney injury. And then the antiemetic therapies that we talked about already can cause prolonged QT. So we want to monitor people closely for that. And then people with hyperemesis have been shown to have an increased risk of thrombosis. Probably because they're immobile, and then severe dehydration can increase the risk of DVT, PEs. And then the last thing to mention is that nausea, vomiting, or hyperemesis can cause mental health decline. And so some people with this, it's very severe, can have suicidal ideation even. So checking on how are their symptoms of anxiety, depression, even PTSD, getting people hooked up with therapists or counselors who can help support them, making sure we are being very supportive and helping with work accommodations or whatever someone might need to just kind of make their life a little bit easier is important. And then the last thing to mention is sort of management of future pregnancies. So the recurrence risk of hyperemesis gravidarum has been reported anywhere between like 15 to 81%. So they're as high as 81%. And so this may be something we counsel people on for future pregnancies, potentially starting your antiemetics or your anti-nausea medications right away before you even have symptoms, or right as the start of symptoms, can help lower the risk of this recurring or progressing into full-blown hyperemesis gravidarum. So in conclusion, kind of what our team here is looking at, because as the nurses on the phones and triaging our patients, you're the first line talking to people often. So this is kind of what we imagine that discussion would go. You obtain your history and kind of assess your severity of nausea and vomiting based on one of these scores. If we have mild symptoms, offering your lifestyle and dietary advice, and then we can discuss over-the-counter use of doxylamine and B6, or send a request from the physician to prescribe those things. And if it is really more moderate or severe symptoms, escalating to the prescriber so we can get additional antiemetics on board before things can progress to be more severe. And so in conclusion, some key takeaway points, just to review and recap. Nausea and vomiting in pregnancy can have a very significant impact on a pregnant person's well-being. Hyperemesis is the leading cause of hospitalization in the first trimester, and the second leading cause of antenatal hospital admissions overall, and it can lead to substantial costs for our healthcare system. It's important to objectively assess the severity of hyperemesis or nausea vomiting in pregnancy using our puke or HELP tools to help guide our treatment. Start treatment early to try to reduce hospitalizations and complications. And then we can really utilize our outpatient infusion centers to help keep people out of the emergency room or the hospital. And this is our references. I think this is all the time we have today. So I would really like to thank you for joining us for this evening round session. I hope this information is valuable and applicable to your work in your clinic and beyond. And just mark your calendars for our next evening rounds, which will be held on May 4th. The topic will be breast pain and breast masses and will be presented by Dr. Mariam Siddiqui. Thank you very much, and I hope you have a good evening.